Hi everyone, my name's Shauna Brandon. I am a new grad from the Nurse Practitioner program at the University of Toronto, and I just recently passed the Canadian Nurse Practitioner Board exam. So today I'm going to talk to you about earaches in primary care. It's one of the most common reasons that parents bring their children in to seek medical care, and it's the third most common reason for all primary care visits. It is definitely something you will see quite frequently in primary care. So let's get started. We'll start with a quick review of the ear structure. So as I'm sure you're aware, the ear is composed of the outer, middle, and inner ear. The external ear, the conch of the nasal cavity, and the external auditory canal are all innervated by cranial nerve number 7. Parts of the external auditory canal receive sensory innervation from the auricular branch of the vagus nerve. So stimulation of this nerve from the external auditory canal can sometimes produce a cough through vagal stimulation. And it is also involved in herpes zoster infections of the external ear canal, and we'll talk more about that in the upcoming slide. The middle ear receives innervation from the cranial nerve number 9, or the glossopharyngeal nerve, and since this nerve is also involved in innervation of the throat and tongue, it's common for throat pain to be referred to the middle ear. And lastly, the inner ear is innervated by cranial nerve number 8, the auditory nerve, and dysfunction with this nerve can result in hearing loss, vertigo, and tinnitus. Now, I want to quickly discuss the eustachian tubes. So the eustachian tubes are tubes that ventilate the middle ear, thereby regulating pressure within the middle ear. They also provide mucociliary clearance from bacteria and other materials that migrate up from the nasopharynx. If the eustachian tube is dysfunctional, it can cause negative pressure to build up in the middle ear, which causes pain and also pulls fluid into the middle ear space in a mechanism very similar to the way a turkey baster works. Stasis of this fluid plus colonization from the nasopharynx can result in an otitis media. So risks for eustachian tube dysfunction include allergic rhinitis, upper respiratory tract infections, craniofacial abnormalities such as cleft lips and palates, poor function of the tensor villi palantin muscles, which are involved in the regulation of the eustachian tube, and these muscular deviations occur in some families and as well as in people with Down syndrome. So if you see the picture here, the difference between the infant eustachian tube and the adult eustachian tube, you can see that the infant eustachian tube is much more horizontal. Therefore, it's much easier for fluid to migrate upwards and to pool in the middle ear, causing otitis media. So the differential diagnosis for ear pain. Eustachian tubal dysfunction or obstruction is usually a less severe pain than associated with otitis media. Patients may report hearing a gurgling, crackling, or popping noise. There may or may not be nasal congestion, and there's usually a unilateral conductive hearing loss present. Otitis externa, which is often associated with tragal pain, referred pain from the throat or jaw, cerumen impaction, foreign body, perichondritis, which is an infection of the pinna and produces a red, painful, swollen external ear, is usually associated with a staph infection, less commonly with strep infections, and tends to be associated with the body of the auricle and spare the non-cartilaginous lobule. Furunculosis, which is an infection of the hair follicles in the outer 1/3 of the auditory canal. Mastoiditis, basilar skull fracture, and you can see there's a picture, let me get my pen here, a picture of battle sign, which is bruising behind the ear and can be an indication that a fracture may be present. Temporal arteritis, tumors, especially consider this in the elderly or people who have pain associated with ear drainage. Contact dermatitis, seborrheic dermatitis, and herpes zoster oticus. So herpes zoster oticus is a viral infection of the inner, middle, and external ear, and it manifests with severe otalgia and associated cutaneous vesicular rupture. It's usually involving the external canal and the pinna. And when it's associated with a facial paralysis, the infection then becomes known as Ramsay-Hunt syndrome. You can see a picture of that down below here. And it accounts for 12% of all facial paralysis and generally has a poorer prognosis than Bell's palsy. So as far as history and physical examination go, you want to ask the pain questions that you would ask for anyone who presents with pain. So where is the pain? What type of pain is it? Is it consistent or intermittent? And if it's intermittent, is it associated with any particular movement, such as swallowing or jaw movements, or is it completely random? What makes the pain worse and what makes it better? Specific to the ear, you want to ask whether there's been any recent air travel or scuba diving, swimming, or recurrent water exposure to the ear. Degree of hearing loss if it's present. So foreign body or cerumen impaction may cause significant hearing loss, whereas middle ear infections tend to cause more dulling of sound, but hearing remains present. You also want to ask about any dental problems, pain with mastication, throat pain, or TMJ disorders. Ask whether a fever is present or not, whether there are any nonspecific symptoms of an upper respiratory tract infection, and as I mentioned, any dental problems. So this is a bit of a bummer, but completely true. Not all red ears are actually infected. I used to think every time I saw a red tympanic membrane that I diagnosed otitis media and I knew what I was doing. But in fact, there are lots of different reasons why a tympanic membrane may be red, and it's not always otitis media. So, in addition to erythema, you also want to consider tympanic membrane mobility, the appearance, whether it's bulging, and whether the bony landmarks are visible, as well as the opacity of the tympanic membrane. So again, looking for hyperemia, bulging with pus of the tympanic membrane, and loss of landmarks are all key in attempting to diagnose an otitis media. So in addition to looking at the ear, you want to make sure that you complete a full head assessment. You want to rule out pain that's referred from mastoiditis or dental abscess, and then looking for signs of middle ear inflammation, as mentioned, that bulging tympanic membrane with marked discoloration and non-tender pinna manipulation. So here in the top corner, there's a picture of a bulging red tympanic membrane. As far as the physical examination, you want to make sure that you're manipulating the external ear, as middle ear and referred pain won't be affected by any manipulation to the external ear. You want to look for a combination of cloudy effusion, bulging membrane, and loss of mobility, as that has a predictive value for otitis media in the mid-90th percentile. And although that sounds really great, there have been studies that show that only 58% of clinicians could state that the patient they diagnosed with otitis media really had an infected looking ear, which tells me that we're not as great at diagnosing otitis media as we think we are sometimes. So down in the bottom corner, I've got two pictures just of options that you can use to help look into the ear, especially of young children who can be quite wiggly and not as compliant as you might hope for. So the first option here is to have a caregiver hold the patient in place as long as they're able to lay down comfortably, and then you can hold their head steady and look in the ear. And the second option, especially for young babies, is to have the caregiver hug the baby really, really tight and hold the head against their shoulder or body in order to keep the head steady and give you the best opportunity to look inside the ear. So as with any topic when studying for the board exam and in real practice as well, you need to consider red flags that you want to rule out in order to ensure that there's nothing more sinister going on. So some of the red flags include tenderness over the mastoid, cranial nerve number 7 palsy, ulceration of the external auditory canal, non-healing lesions in the auditory canal, and ear lobule erythema. All of those could signal that something more sinister is going on and require further investigation. And this is not an extensive list, but it's just something to get you started thinking about those red flags. So acute otitis media, as I mentioned, this is something you will see so frequently in primary care. It's often associated with an acute onset of ear pain, which I used to think was the best way to possibly identify otitis media, but It actually may be absent in up to 40% of those with otitis media. So if you're using ear pain as the primary diagnostic criteria for otitis media, you may be missing a number of cases. Other signs and symptoms of otitis media include fever, irritability, nighttime waking, decreased appetite, ear rubbing, otorrhea, nausea, vomiting, diarrhea, and conductive hearing loss. There may be anterior cervical lymphadenopathy on the ipsilateral side, and it's often preceded by an upper respiratory tract infection. And this occurs because it leads to a dysfunction of the eustachian tubes, and that allows nasopharyngeal pathogens to invade the middle ear and cause the acute infection. So as I mentioned, it's so common in most frequent diagnosis in sick children, and the most common reason for antibiotics to be administered. The peak incidence is between 6 and 15 months of age, and approximately 85% of children have had at least one episode by the time they are 3 years of age. So bacterial causes of acute otitis media include strep pneumo, H. influenza, M. catarrhalis, Staph aureus, and group A strep. So strep pneumo has the lowest rate of spontaneous resolution, with only about 10 to 20% resolving spontaneously without antimicrobial therapy, and it tends to cause more severe disease and a higher fever. So when you're treating someone with otitis media, really that's the one that you're thinking about treating, that particular infection. Viral causes can include RSV, influenza, parainfluenza, and adenovirus, and it's often common to see viral and bacterial co-infection. That occurs in about 66% of all cases. Risk factors for otitis media include exposure to cigarette smoke and air pollution, daycare attendance, First Nation or Inuit ethnicity, formula feeding. We all know that breastfeeding is protective, but if you have a patient who is formula feeding, you want to encourage any avoidance of supine bottle use, especially. Use of pacifier after the first 6 months of life, household crowding, premature birth, young age, family history, and orofacial abnormalities. So that includes a cleft palate even after it's been repaired. Treatment for otitis media, you always want to make sure that the vaccinations are up to date. That's the best treatment option that we have, really, is prevention of otitis media to begin with. After you've confirmed the diagnosis, you need to consider the age of the patient you're working with. If they're less than 6 weeks old, it's recommended that they be sent to emergency for further investigation. 6 weeks to 6 months, you want to start antibiotic treatment immediately. Watchful waiting is not recommended for this age group. And after 6 months, watchful waiting is a viable option. You need to consider the severity of disease presentation for the patient, and also whether there is appropriate supervision that would be able to recognize worsening of symptoms and have the ability to return for follow-up assessment if necessary. So it's a joint decision that's made between the provider and the caregiver, and we usually recommend watchful waiting for between 48 to 72 hours. If you find that there is a caregiver who is hesitant to consider watchful waiting, it may be helpful to provide some education to the caregiver and let them know that most otitis media spontaneously resolve, about 80 to 90% spontaneously resolve without any antibiotic treatment. The number needed to treat with antibiotics to improve symptoms is 8, and the number needed to treat to harm is 10. So as you can see, the first recommendation for antibiotic treatment is amoxicillin, 80 milligrams per kilogram per day. And the reason it's a high dose of amoxicillin is that you need a high dose to ensure that a therapeutic dose of the antibiotic reaches the middle ear. Watchful waiting, I should also mention, is not recommended for children who are immunocompromised, who have chronic cardiac or pulmonary disease, anatomic abnormalities of the head and neck, Down syndrome, or a history of complicated otitis media. Azithromycin can also be considered for patients who have a type 1 hypersensitivity to beta-lactam antibiotics. And if there is perforation of the tympanic membrane, either chronic perforation or ventilation tubes in place, then you need to consider topical fluoroquinolone dexamethasone drops such as Ciprodex. And as always, you need to consider the antibiotic resistance in your area. Parents often want to know if their child who has otitis media should be referred to an ENT for further investigation. The recommendations for referral are any child who's had 3 episodes of otitis media within 6 months or 4 or more episodes within a 12-month period. They should be referred to ENT for consideration of tympanostomy tubes. If children have recurrent otitis media, then they should also be referred to an audiology for assessment regarding potential conductive hearing loss. Most children with otitis media will develop an otitis media with effusion. And there's no need to treat this in an asymptomatic child, but we should consider referring to audiology if it persists for more than 3 months, as this can affect long-term speech and development patterns. If recurrent treatment failure occurs or there are recurrences of unresponsiveness to treatment, then we should also be considering a referral to ENT for culture of middle ear fluids to identify pathogen culture and sensitivity. Otitis media with effusion is also colloquially known as glue ear, and it is the presence of fluid behind the middle ear and can persist for 4 to 6 weeks, in some cases up to 3 months or longer. It's the most common cause of pediatric hearing loss and may occur spontaneously due to poor eustachian tube function or as an inflammatory response following an acute otitis media. So as you can see, in 10% of children, the otitis media with effusion can last for more than 3 months. Signs of middle ear effusion include opacification of the tympanic membrane with loss of bony landmarks, visible air fluid levels, decreased tympanic membrane movement, and the presence of liquid in the ear canal. So you can see here there is that sort of glue-like appearance of the tympanic membrane. You can also see some bubbles up in the upper portion of the tympanic membrane. So complications of otitis media with effusion include hearing loss, speech delay, learning problems, especially in very young children, chronic mastoiditis, ossicular erosion, and cholesteatoma. As far as treatment for otitis media, it's important to know that decongestants are not approved for children under 6 years of age, and they have not been shown to be effective in treating effusions. So cholesteatomas are an abnormal growth of squamous epithelium that's trapped within the skull base and can cause erosion and destroy important structures within the temporal bone. Its potential for causing central nervous system complications such as brain abscesses and meningitis make it a potentially fatal lesion. So definitely an important do not miss diagnosis. The last cause of ear pain that we're going to talk about today is otitis externa. It's an infection or inflammation of the external ear. It usually is associated with recent ear canal trauma or conditions that hold moisture in the ear canal, such as swimming or cerumen impaction. And it may be accompanied with a cellulitis, especially in the presence of protracted infection or comorbidities such as diabetes or immunosuppression. Swimmer's ear is often more an inflammatory etiology than an infectious one, so it may be helpful to suggest installing a few drops of vinegar or alcohol post-swimming to help dry up the fluid in the ear canal. Signs and symptoms of otitis externa include pain with movement of the pinna and tragus, ear canal that's erythematous and edematous. It's often very painful for these patients to have the otoscope exam done. There may be purulent or serous discharge, and there's usually no fever present. Treatment options include, if the tympanic membrane is intact, Burosol drops. If it's perforated, you want to move on to the Ciprodex drops. And if there's any indication of cellulitis, you want to consider an oral antibiotic to treat that. If symptoms are described as more itchy than painful, then consider the possibility of a fungal infection as the cause of otitis externa, and that you would want to treat with an antifungal such as clotrimazole cream. And last point is malignant or necrotizing otitis externa is an infection that invades the deeper soft tissue. It's more common in people who are immunocompromised or who have had radiotherapy to the skull base, and it may result in osteomyelitis. So presentation includes findings of otitis externa plus pain that's out of proportion with clinical findings. Anytime pain is out of proportion of clinical findings, it's definitely a red flag to investigate further. And the CT is the preferred imaging for this particular condition. So that is it for this presentation. Please let me know if you have any questions or comments in the comment section below. Thank you.